Before we get started, please remember this podcast is for general educational purposes only. We're not providing medical advice, diagnosis, or treatment. Always consult your own healthcare provider about your care. Welcome to Fertility Nurses Unfiltered. 2 nurses, 1 mic, no bullshit.
I'm Ashlee LaRue, fertility nurse and founder of Fertilities.
And I'm Laura Wepler, fertility nurse and founder of Navigating Fertility with Laura.
You got questions, the internet has a lot of opinions, but what you really need is 2 fertility nurses who aren't afraid to tell the truth.
No scripts, no sugarcoating, just honest, evidence-based nurse-to-nurse conversation. So let's get into it. Hey everyone, welcome back to Fertility Nurses Unfiltered. I'm Laura here with Ashlee, and this week we're talking about all things IVF, what actually happens leading up to IVF versus what people I think perceive that happen. And one thing I just wanted to start off by saying is just because you need to see a fertility specialist doesn't automatically mean that you need to do IVF. I had this conversation with a client last week who assumed that because they were going to need to go see a fertility doctor because they'd been at that 12-month mark of being unsuccessfully trying naturally, the assumption, at least by this client's husband, was, well, I don't want to go to the fertility clinic because it automatically means that I'm going to need to do IVF. And so I just wanted to start off by saying that that's not always the case. Usually we do try other interventions first. But this episode's really going to focus on, okay, let's assume that IVF is the path that's recommended for you. What is that? How are we actually getting to that point? What are all the things and all the steps that it takes to get to that point of IVF? And then what actually is it and what is it not?
Yeah, I think that's a really good call out though, straight from the start, because I think that is something that is very much perceived in the community. I think a lot of people don't even call their clinic their fertility clinic. They call it the IVF clinic. Or even like outsiders, they call it the IVF clinic. And we do so much more than IVF. Mm-hmm. And so absolutely, I think that's a great call out to get this started, that just because you're seeing a fertility specialist doesn't automatically mean IVF. It may. And that's a decision between you and your provider and what you're comfortable with. So I think that's a great call out from the beginning. But I think that's why we also wanted to have this episode is let's throw it all out there. If you are going through IVF, if that is the path, what realistically can you expect? What are some things that aren't really talked about quite as much? And this is going to actually be a 2-part episode. So the first part, we're going to talk realistically what kind of IVF and leading up to it and things that aren't talked about quite so much. And then part 2, which I'm really excited about as well, is we're going to dive into more social media and what the outside world kind of tells you needs to be done, or what to expect for IVF, or what you should prepare or do beforehand, which I'm really excited to kind of debunk and talk about what's real and what's not when you see those kind of stuff on social media. So stay tuned, 2-part episode this time. Really excited to dive into both.
Yeah. So I think to kind of dive into this episode, we wanted to kind of talk about, and I guess this goes hand in hand with where I started with, okay, when you see a fertility specialist the first time, right? I think people may assume they go into that first appointment and they're going to have a conversation and right away it's going to be given a recommendation, you know, hey, this is what we're going to do next. But unless a patient's coming in from maybe some testing they've done with their OBGYN, maybe, for example, maybe they found out that they have blocked fallopian tubes, right? Or maybe for a medical reason, maybe they had to have their tubes removed. Or, if there's a clear indication that IVF is the intervention that needs to take place, most of the time what we're doing in that initial first month of seeing a fertility specialist is going through a whole series of testing to kind of uncover why someone hasn't gotten pregnant. And so, we could probably have an entire episode and lecture on that. That's not what today is for. But I think there's some really important testing components to call out. One specifically, I just want to call out from the beginning, being genetic testing. This is something that I would say the majority of clinics, if not all, will offer to patients when they come in. And what we mean by genetic testing, I think the term genetic testing is thrown around very loosely.
Yeah.
And it could mean like a million different things. And it's not looking for things like I'll always hear people say, well, I don't need to do genetic testing because there's nothing like wrong in my family history.
Yeah.
And to clear that up even further, a lot of genetic testing, most of the time in natural conception, genetic testing is done at the point that somebody's already pregnant. When we're going to be doing any sort of intervention to assist someone in getting pregnant, we do genetic testing from the get-go to identify anything that we might want to be aware of ahead of time. So genetic testing really is what we call genetic carrier screening, where we're looking for disorders or conditions where one or both parents are carriers for the same genetic condition. And so it can be really beneficial information for couples to know prior to starting any sort of fertility treatments, whether they are a carrier for a specific genetic condition, and does that warrant additional testing for a partner or additional screening of embryos should IVF be the route that we go.
Yeah, I think that's a really good call out because that's something that you don't hear as much in the OB community. I think, if somebody's coming from their OBGYN and potentially had some fertility testing initially, that's not something that's really talked about. The OB doesn't really bring up genetic testing, at least very frequently, or in my experience that I've seen. So that's something new that, our, patients come in and they start talking about genetic testing. It's like, well, why am I doing genetic testing when my OB didn't talk about this or something like that. So I think that's a really good call out from the beginning, that there are more testing options that the fertility doctor has at their disposal, that they're going to talk about, that they know about, more than just your OBGYN. So I think if it's a question of you've been trying to conceive for a little while and you're questioning whether, maybe you've had conversations with your OB, maybe you've even had some tests with your OB, but you just want to talk to a fertility doctor, and because there may be some more that they think about, because that's what they do on a day-to-day basis. Right. I think another great call out is not only do you have to go into IVF, you don't even have to go into treatment right away if you see a fertility doctor.
Totally.
I mean, you could see a fertility doctor. I think that's a big myth out there, is like, I'm seeing a fertility doctor and all of a sudden I'm going into fertility treatment. That's not necessarily the case. We may just do some testing and the doctor could say, okay, what are your thoughts and wishes, and have a conversation with you. And it doesn't actually have to mean that you go into treatment. So I think that's a really good call out to kind of say there's so much testing out there. There's so much your OB can do, but there's so much more that your fertility doctor can kind of help you with. But I think that leading into IVF, going back to, if IVF is the goal, I think that's a piece that a lot of people get a little frustrated with, is this testing component.
Well, and that's kind of where I was going, is there could be this delay from doing that testing. Because just to explain to our audience, when somebody is tested so genetic carrier screening is a blood test where we look at a panel of different diseases that somebody could potentially be a carrier for. So like I always use cystic fibrosis as the example because that's the one that most people have heard of. Cystic fibrosis is a condition where both the sperm and the egg source have to be carriers for the same for cystic fibrosis. Sometimes we test one partner and they're a carrier for something. It is our due diligence as fertility professionals or as women's health specialists, right, to test the partner to confirm that there's not an overlap. I've definitely worked with patients who have had children born with genetic conditions where both parents are carriers. And now that that's known, right, we can prevent that through IVF. And this could, we're not going to go down a whole rabbit hole with this, but that could potentially be a reason that someone does IVF to try to reduce that risk or essentially eliminate that risk of a child being born with that condition. So all that's to say, if we test a female partner and she's a carrier for something, it does take time to get these results back. And so that can present one of the delays to starting treatment, is now we do need to test the partner.
Yeah. Well. I mean, it can take up to a month to get these results back, just to give you kind of a general high level timeline. So I think that's a really great call out for timing, right? I think is a big piece that a lot of people don't really understand going into it. And the testing before you begin is a big component of that. I think some people go through fertility testing for about 1 to 3-ish months before they go into IVF. That's high level, and it definitely differs from person to person. But if your expectation when you saw the doctor was, okay, I want to get started right away, that can be frustrating when you hear like, okay, we've got to do all this testing first. But I think just kind of, Laura's example of genetic testing is just we want to do the testing up front. I think what I try and explain to a lot of people is if we don't do the testing up front, and let's say we didn't catch something at the very beginning and you've spent all this time, energy, money, all of this into IVF or any type of fertility treatment, and then we find something later, you're going to be even more frustrated that we didn't do the test early on.
Right.
So
then we have to backtrack.
And then we have to backtrack and that's just not good for everyone, especially you as the patient. So I think having an understanding that the testing is super important. Yes, it's really annoying that you're going to have to do some additional testing before we jump into potentially getting into treatment. Because if your goal is to have that child, you want to move forward sooner rather than later. You're seeing the doctor, you're seeing that fertility doctor, and there's that hope there. And we all have that hope for you, but we want to do it the right way to give you the most optimal outcome possible. So I think knowing that testing can take some time, knowing that testing supersedes treatment and the importance of it helps you to set that expectation going in. And so it just feels a little smoother transition as you start seeing a fertility specialist.
Yeah. Yeah. And so, okay, so there's a series of testing, right? You enter the fertility clinic, and we're just going to keep going on this assumption, right? This is a person entering the clinic who knows they need to do IVF for one reason or another. So as Ashlee said, that testing can take anywhere from 1 to 3 months. I think part of the reason for that is a lot of the testing that we do in fertility is cycle specific.
Yeah.
It's related to the timing of a woman's menstrual cycle. And so there are certain tests that need to be performed on certain days. So that can obviously push the timeline out a little bit. And then from there, once we have that testing information, your doctor that you're working with is going to determine a specific protocol for you. And there are, quote unquote, what I would say are cookie cutter protocols, but I would say there's a lot of variations of protocols.
Yeah.
We kind of have standard ones that we follow and then we make little changes to them.
I feel like I like to use the analogy, it's like a recipe.
Yeah.
Like we have our basic ingredients, right? You're baking bread, you got your flour, the basic ingredients, every clinic, every doctor's sort of following.
Yes.
But then, if you're making it with love and changing it up and throwing, or you're eyeballing things. And so, a lot of it's science and you need certain things to make that recipe. But there are certain things that are very specific to that recipe or to you or to your family. And that's kind of how I see, protocols being is like the doctor sort of creating a recipe for you. So there's some standards, but there's also, some things we can do to change things up.
Yeah. Yeah. And so I think where a lot of patients get frustrated on IVF timing because one ingredient to that recipe, I like this analogy, for a lot of people, not all people. But I would say in most typical IVF cycles, there's like a month leading into injection start of some sort of priming. I would say a good amount of the time we use birth control, and it seems really counterintuitive. Why are we using birth control to try to get somebody pregnant? But it, high level, what it does is it helps assist the response that then we get when we start injection. So it seems really counterintuitive. It seems like, why am I, just taking a pill for 2 to 3 weeks and now I have to wait even longer? It actually can improve the outcome of the IVF cycle itself. There's all kinds of ways, just like a recipe for the actual stimulation cycle, there's a recipe for priming. So there's a lot of different ways that we can do that. But again, I think for the majority of people, there's this leading up phase to IVF. So now we've got testing, that kind of initial pre-testing phase of 1 to 3 months. Now we've thrown in there a priming cycle of, usually about a month. And it's not right. So we're already like 2 to 4 months in before we actually even start the IVF cycle.
Yeah. I think that time in there is not talked about enough, right? I don't think a lot of people, and it's going to be different for everybody. Some people, again, it's going to take 1 to 2 months, and some people it's going to take that 3, 4, 5 months. And it's not that you're doing anything wrong if you're on the longer end of the spectrum. It's just maybe we had to do some additional testing. Maybe your body wasn't, giving us what we needed to do whatever. So don't think you're doing anything wrong if you're on the longer end of kind of leading up to a cycle. But just understand that it does take some time, and there's a reason behind that time. And I think talking about it normalizes it, and so gives you that expectation before you kind of go into that cycle. I think another piece as we're leading up to like starting stim, not only testing, not only priming, but something again that gets talked about a lot, but should be talked about more is the cost and insurance and finances. And, there's another non-clinical component that's happening in the background leading up to a cycle, and that's financial. Whether that's getting prior authorizations from your insurance, maybe that's, prior authorizations for medications, maybe that's, maybe you're paying out of pocket for medications. So you're looking at all different types of pharmacies,
and then there's nuances between insurance companies.
Yes.
We used to, it was always in the clinic. I was like, oh, good, this patient has Blue Cross Blue Shield. Like, we're going to get this authorization much faster versus, oh no, this patient has Aetna. It's going to take a month to get this authorization.
Yeah.
And it kind of goes back to our conversation that we were having last week about all of the things that the nurses are doing. One of the things that we do and we're responsible for is getting the green light from the financial team to actually
financial clearance. Yep.
Yeah. So everything could be like aligning perfectly medically, right? And we could be saying, yeah, based on where you're at in your cycle and the protocol, this is when we're aiming to start. And then we could get this wrench thrown into it from insurance. That's like, sorry, we don't have authorization yet for one reason or another. So that absolutely, I'm glad you brought that up, can be a huge aspect to starting
and
IVF.
That I think that goes along with like priming too, because you could be starting priming and all of a sudden we have to stop it or divert or do something because of financial reasons, and that can feel super frustrating because medically, clinically, you are cleared to go, and because of insurance or finances, you're not able to. And that is beyond frustrating and not the way it should be. And again, we could have an entire topic. We will at some point.
We will.
Have an entire conversation.
We're bringing this up every week. Insurance has got to be like a whole week topic. If anybody out there works for these insurance companies, or there's any financial advisors at clinics that want to come in and talk to Ashlee and I about this, I think it would be a great conversation.
Yeah, but I mean, it's the reality of it, right? Is this costs a lot of money. So yeah, we need that insurance. We need that. We need things to be lined up, but that doesn't mean it's not a piece of the puzzle that can be very frustrating and be a part of that time commitment or restraint as you're trying to navigate, leading up to IVF. I think, that's a big frustrating piece leading into it. I think something a lot of clinics are seeing, and I want to explain this so people understand. There's not only waiting lists for seeing providers at a fertility clinic, there are also waiting lists to start an IVF cycle.
Yes.
Yeah. At a lot of clinics.
I think we're seeing this more and more too,
Yes.
because there's a huge embryologist shortage.
Yes.
Yeah.
So, and that's the reason behind it, right? Is that we need to make sure that our lab, it doesn't hit capacity. There's only so much. Things have to happen at a very specific time when you're egg retrieval. And then, they have to pull out those mature eggs at a certain time. They have to fertilize at a certain time. Things have to happen kind of boom, boom, boom in order for things to go correctly. And a person actually has to do those things right now. So I think that's another component that can be very frustrating for a lot of our patients is, okay, again, you're geared up, things are going, okay, maybe your clinic has a couple week waiting lists to get on the IVF cycle list because they're trying to cap it at a certain amount in order to not overexert the embryology lab.
It's for safety. I think that's super important to call out, especially, when you do hear stories in the news about embryos getting mixed up or, things that went wrong in the lab. And I think a lot of that has to do with clinics are trying to create the safest environment to handle patients' eggs, embryos, sperm. And so we need to make sure that we are not overextending our staff, who is the ones at the forefront of dealing with those things. So it's, you know, it's a frustration for patients, but I think if we can kind of change the way that we're thinking about it, again, nothing's going to change the frustration of, oh my gosh, this is drawing out. I wanted to be pregnant yesterday, and now this is drawing out the process longer. But if you can kind of think of this as being in your best interest for your safety, that's the reason why.
Yeah. And I really just wanted to make sure that we talked about that. Cause again, I think that's something that's not talked about enough or isn't brought up enough, is like one of the reasons that, you know, there is this waiting piece. There's so much waiting in fertility, and I know it sucks, and I don't want anyone to wait either. Hurry up and wait all the time. And it's terrible and it's annoying. I totally understand it. But for this, I just wanted people to understand the reasoning behind it, and that it actually is for safety. It's for your benefit, that we are treating your genetic material as safe and secure and quality as possible. So I think it's really a call up. But back to financial, just really quickly, I did just want to mention, I think another piece that people kind of were, again, I'm going to put it on spotlight because no one talks about this kind of stuff enough. But a lot of times you have to pay for your cycle up front before you start your IVF cycle. And I've seen this actually a lot, come up a lot. And with clients I've talked to, and so on social media, it's talked about a lot. But you have to pay for your IVF cycle. Any out-of-pocket has to be paid for up front.
Before you start any injections.
Before you start. Yeah, exactly. So you should be getting like a detailed list of everything that you're paying for, everything you've agreed to. I think there's a piece of that too that gets missed, is there's a lot of hidden costs in IVF. There's a lot of quote unquote extras. Like you say, you know, here's so-and-so's clinic's IVF package. But if you are, you know, anesthesia is usually extra. It's paid separately depending on what the clinic is using. Genetic testing is a lot of times paid separately or in like bundles. Like if you have 6 embryos, it's this cost and this and this.
And on that real quick, just to clarify, genetic testing, because again, this is a term that gets thrown around. We mean embryo genetic testing, and a component there, I think, that throws a lot of patients off is they don't realize there's typically 2 costs associated with that. So there's the fee that gets paid to the actual clinic to perform the embryo biopsy. So but then there's the separate bill that's going to show up. Not in all clinics. I think some of them do in-house PGT, or they have, it gets paid directly, but there's a lot of genetic testing companies out there that you would then get an invoice from that specific genetic testing company who actually runs the analysis. And that I think throws a lot of people off. They think I already paid for this. Now you're getting a separate bill from the genetic testing company.
Yeah. So I think there's a lot of like hidden extra costs that, again, like you think, you know, IVF package, okay, great. That's what it is. But then you get your super bill or whatever, and you're asked to pay this up front. And there's a lot of questions like, what is this? And, you know, not every clinic has a financial advisor or somebody, a counselor that can sit down and explain to you, this is what this is. This is, you chose this. And so this is why this is here. And that can be not already, the financial piece is extremely frustrating to a lot of people, to even the clinics and the nurses and everybody even working it. It is super frustrating. But then to get like a bill with like an extra cost you weren't expecting, and then you're expected to pay for it upfront before the cycle even starts, I think, again, adds to that frustration that not enough clinics are talking about ahead of time and setting that expectation. So that's why I wanted to call it out on here, because it is part of the reality that you may experience.
Yeah. I think another big one is reasons why a cycle might be delayed due to a medical reason. And this happens all the time, where a patient will go in for their, you know, everybody before they start IVF gets a baseline ultrasound and a baseline laboratory check. And we're looking at the ovaries. We want to make sure they're quiet, that there's nothing going on that's going to interfere with starting injections. And hormonally, we want to make sure that your hormone levels are, quote unquote, what we call baseline. Because if they're not, if we have elevated hormones, we could give you injections, but you're not going to respond, right? And so when somebody's baseline results come back abnormal, it can delay the process. And I see a lot of patients thinking that it's their fault, or they get really frustrated. One really common thing that I see all the time is they go in for a baseline and there's a cyst on their ovaries. And it's important to point out that the majority of cysts are what we call simple cysts, and they are just common in menstruation, in women of reproductive years. It's not a bad thing. Again, in majority of the cases, it's nothing concerning, but it does interfere with the process. And so now we need to put things on hold because we need to let the cyst resolve before we can start injections. And that can be really, again, it's really common. So if it does happen to you, or you're listening, you're like, oh my God, this happened to me, you are not an outlier. I see this all the time.
Yeah. But it doesn't mean it's not super annoying, because
it's so annoying.
All these pieces we just got done talking about: the testing, the financial aspects. You've gone through your priming, you are ready, you've gotten all your meds. So much has already happened, and you're like, let's just get this thing going. And then you have a cyst on your ultrasound, and it's just this deflating, like, what the heck? Like, I was ready. I did everything. I prepared. And I think it's right, exactly what Laura said. One, it's common. So please know you're not alone. But two, it's not your fault. They happen. They show up. Sometimes we don't even know why that happens. But it doesn't make it any less annoying. And especially if that cyst sticks around for a while, which they can sometimes. Most of the time they resolve on their own, or we trigger it, or we do something. But I've had people where it sticks around for cycle and cycle. And so we're having to, maybe even drain it.
I was going to say, yes, sometimes we have to go in and drain it.
Sometimes we have to go drain the cyst, which is another procedure that you have to do. But again, it's this I think the biggest thing is time and waiting, right? Is a big thing in fertility in general, but going through IVF and so many different components, so many frustrating components, can be that time and that waiting. I think is high level what we're kind of trying to say, but it's also, I think what we're also trying to say or point out is we're not trying to be negative. I think a lot of the things that we're saying on here seems like we're saying like there's a lot of like negative components to IVF. IVF is beautiful. It helps so many individuals and couples have their family. But in the same token, it's a lot. There's a lot that goes into it. And I think we just want to be very transparent with all of our listeners. I think that's one of the things we wanted on this podcast, to be very unfiltered, very transparent, very honest. And so I hope our listeners don't feel like we're coming across negative. We're just trying to throw everything out there so you know what to expect. I was
going to say, I think
normalize stuff.
Right. I think a lot of this is giving people the knowledge that I don't think we typically educate on in the clinic setting, right? Because there's so many things that we're responsible for, as we've talked about in our last episode. But if you're prepared that something can happen, you're going to react to it. It's still going to suck, right? If you're going in for your baseline appointment, there's the possibility, even though it happens, but it doesn't always happen. But if you go in and they find a cyst, and you knew that was something that could happen, I think it's a lot easier to take that news if you already were prepared up front that this does happen sometimes. And it delays things a little bit, but it doesn't mean the end of the cycle. I think it's a lot easier to digest, but we just don't talk about these things. And so patients go in and they get a baseline ultrasound. They're told they have a cyst. And again, I see people then start to go down this rabbit hole of, oh my gosh, people will think as far as like, do I have cancer, right? Because I have a cyst.
Cyst sounds scary.
Cyst sounds like it's, or, I already know I have polycystic ovarian syndrome. I'm like, no, this is totally different. Like, that's not what that means. But I think, if we are preparing you for the things that can happen, I think that you being a more educated patient will make it a somewhat easier experience.
Yeah, I agree. And I think that's the whole point of this, right? Is to set you up for success and understanding and having all the knowledge possible, but clarity in that knowledge. So if you do encounter something or time there's a lot of waiting or these different components do happen to you, oh yeah, Ashlee and Laura talked about that, and again, just hopefully normalize and make it so like, okay, yep, this is something that can potentially happen. And maybe you're not quite as frustrated is the goal.
Yeah. Yeah.
I think we take a step back. I think we missed two things that I think you and I wanted to touch on before we kind of head into like the cycle itself.
Yeah.
I think one of the pieces is under the testing component. I just want to make it very clear. We've talked a lot about female testing. If you have a male partner or even a female partner, when we talk about testing, we're talking about both individuals or both partners or both people that are going to be a part of the process. Mm-hmm. So I don't want to leave out the partners in this conversation by any means. So just know that when we talk about testing, it's very important that we are talking about both individuals. I think Laura touched on it when she was talking about genetic testing or genetic carrier screening. We want both partners that are going to be genetically involved to partake in that. But there is testing that we do for each individual partner. Again, giving us as much information as possible to give you the best protocol possible, and give you the best plan possible to give you the outcome you want. So yeah. I did want to hit on that really quickly. And I think the other thing, actually, Laura and I brought this up before we got on and we're going to talk today, but we were talking about how provider nuances can be. Yeah. So provider nuances. And what we mean by that is, maybe you've seen multiple fertility doctors. Maybe you have a friend that's also going through fertility treatment and their doctor is doing some type of testing, but they didn't do that testing on you.
Or it might even be the same doctor. I've had that too, because you are an individual and fertility is not linear, it looks different for you.
Yeah. And I think this is something that we see a lot, not to bring up social media because we're going to have a completely separate topic on that. But I think that's something that we see in social media too is, oh, my doctor did this testing. And then you're starting to think, well, why didn't my doctor do that testing for me? It's very easy to start comparing different scenarios or different people's situations. And when we talk about testing, there's so many different things that we can do. Not every test is meant for every single person.
Yeah.
So wanted to call that out really quickly too, kind of backtrack a little bit and just kind of bring those to light because it's probably stuff that, you all are seeing and hearing.
Yeah, no, I'm glad you brought that up. I think, let's kind of talk about now, okay, let's say you've done all your testing, you've gotten the financial clearance, your baseline ultrasound and lab work came back clear. You have the green light to start injections. Yay. What does this look like now? Yeah. And so, again, some of this is going to depend on your specific protocol. If you're doing a fresh embryo transfer, if you're doing a frozen embryo transfer, if you're doing embryo genetic testing, this can look a lot of different ways. But the timeline for an IVF cycle can be variable for different people. I usually tell people, actually, I'm curious what you say, but I usually say like roughly 8 to 13 days. It's kind of, you're on injections for roughly 8 to 13 days. And it sort of depends on how you're responding. Do we need to make a dose change? So I think right off the bat, one thing that's not necessarily a delay, but I think patients view it that way is they start their injections, they go in 3-4 days later, and nothing's really moved, right? Yeah. Their hormone levels haven't shifted. We're not really seeing any movement on the ultrasound. And I think a lot of people start to catastrophize right away of, oh my God, like this isn't going to work for me. Yeah. And I equate IVF to stepping on the gas pedal in your car. If we slam on the gas, we're going to like speed out of the gate really quickly.
Yep.
We want to kind of ease on the gas because the goal is that your ovaries are responding, I guess synchronously. I'm trying to explain this so I don't use terms that are not that are not known for our listeners. So like when we think about stimulating the ovaries, we want all of the eggs that we're trying to retrieve to grow at the same rate. Mm-hmm. We don't want one or two speeding out of the gate, which is where that gas pedal analogy comes in. But that can really frustrate people as they see it as a delay. Really, it's okay. We didn't get the starting dose right. We need to up the dose and now we can move on. And so maybe you just have a little longer cycle.
Yeah. I think slow and steady here. And again, that's not what people want. Like people want yesterday to have that family. So hearing slow and steady is not something maybe you're wanting to hear, but it's exactly what Laura said. The slower we can kind of ease into things, the more that those follicles kind of synchronize together, they start growing at the same time. And that's ultimately what we want, to get as many follicles or eggs retrieved as we possibly can. So I think that's a really excellent point. I think a lot of people don't realize how small things are at the beginning, and then to like measure, we sometimes can't even see certain things if it's like hiding behind another follicle or positionally, because early on it's so small. I think Laura, you've probably seen this as well, but you go into those early ultrasounds and there's like an antral follicle count, and then the first scan, you get a little lower number. So like the initial number was something, let's call it 10. And then, you go in for that first scan and they're only measuring 6. And you're
Yes,
like, well, what happened to the other 4? Don't give up on the other 4 yet.
they're still there. They're just not measurable yet, is what I tell
Yeah.
people.
Yeah. So those earlier stages, the first couple of days of IVF, try not to get too discouraged on like what you're seeing. We're kind of like learning your body's reaction to the medications. How heavy do we need to step on that gas pedal? I love that. I'm going to start using that. Do we need to come off of it a little bit? Because we do have some that are growing a little bit faster. So I think slow and steady is really important. And I think very early on, just try not to get too discouraged on like what you're seeing. And if you're seeing some smaller numbers or 1 or 2, 10 are a little hidden, it's just because it's very early on and those follicles are really tiny.
Well, and I always say too, ovaries are 3-dimensional structures, and an ultrasound is measuring in 2 dimensions. So there's also user, I don't want to say error, right? But like things can look different a little bit from scan to scan, depending on the ultrasonographer that's doing the scan, or based on the way that your ovaries are positioned that day.
Yeah,
the ovaries they can move. Sometimes we can't see an ovary because maybe it's hiding way up in the bowel. Maybe there is like bowel in the way. So there's like just a ton of nuances, I think, is the point on what we're seeing on those ultrasounds. And it's really important in those early days on the ultrasound not to get too wrapped up in the numbers. I really like to use lab values more, especially that estrogen level as a gauge as to how things are going.
Yeah, especially early on for sure. If that estrogen's rising and you're seeing that change, we're making progress.
Yes.
That's your slow and steady progress. We don't want that going too high. We don't want it to be too low. But again, early on, it's less about the follicular size or the follicle size until we get a little bit like further along. They're kind of popping out there. We can see them a little bit more readily. And we have a little bit better set expectations. But I think Laura hit it right on the head. This is about a 2-week process from starting injection. So assume
to the egg retrieval.
To the egg retrieval. Yes, I'm sorry. To the egg retrieval. It's about a 2-week stim process. So you start your injections. It's going to be about 2 weeks, give or take. Everyone's different. How long until that egg retrieval is going to be. I would say people are going into the clinic. I usually tell people 6 to 8 times during about a 2-week period.
Yeah. Give or take, depending on the clinic.
Give or take.
Say that's right. Yeah.
That's a lot.
It is a lot. And it's done in its early morning too.
Yeah. It's early morning. And a lot of times we don't know your next appointment until the previous appointment because we're measuring things and we're like, oh, you're going really quickly or you're going a little faster. We want to see you tomorrow because we changed your dose, or, oh, things are looking really good. We can go 2 or 3 days before we see you. Clinics do their best to give you an estimation of when you're going into the clinic, but you've got like the biggest thing during the cycle, I think, that gets missed is the flexibility. Yeah. You don't know when you're going in. It's going to be early morning, which maybe when you're starting work. So you've got to kind of figure that out. Maybe get a doctor's note or move some meetings around. Try not to be traveling during this time period or have a whole lot going on just because there's already a lot going on. Yeah. And you're going into the office probably, about half the time that you're stimming until that egg retrieval. And that's a lot. You're doing lots of injections. You're going into the office a lot, which kind of disturbs your life. And already all this stuff is kind of embedding itself into your daily life. And that can feel like a lot.
Yeah. Yeah. Oh, I just had another thought and it kind of left I know what I was going to say. I want to kind of tie the financial into this a little bit. One area that I find that's frustrating that patients don't often realize is that the medications prescribed at the beginning of the cycle are what we assume you might need.
Yes.
If there are dose changes, it is not uncommon for patients to need to order additional medications midway through the cycle. And especially if you're somebody who's self-pay for those medications, it can come as a real shock when you're being told 8 days in that you need to reorder your Menopur or your Follistim. So I think it's really important for people to know when they start an IVF cycle. It is very common. It doesn't happen every time, but it is very common for you need to order more injections. And that first order may not be the entirety of what you're paying for meds.
Yeah, no, that's a huge call out, and something I think that's a big nursing pro tip is you've got to keep track of your medications.
Yeah.
Because
especially going into a weekend.
Yeah, especially going into a weekend or a holiday and those pharmacies are closed. And for a lot of people, we order these medications to a specialty pharmacy. A lot of people, depending on where you live, you can't walk into a CVS or a Walgreens or a Rite Aid and pick up these medications. They've got to be from a specialty pharmacy. And for a lot of people, especially if you have insurance or you don't live in a bigger city, those are mail order, meaning they ship those medications to your house. That can take a day or two.
Right.
So always stay on top of those medications. How many doses do you have left? Communicate that with your nursing team if you're concerned. If you're getting low on something, they can kind of help you time some stuff out. But especially if you're self-pay, but also even insurance. Insurance will dictate how much you can get at a certain
That's
time.
true. Yeah.
So I know, for example, progeny. I think a lot of patients going through fertility treatment have progeny, or at least have heard of them. I think they cut it off at 7 days. So they only give you 7 days worth of stim medications, and then you have to order more based on kind of what they're seeing.
Yeah.
That can be a huge frustrating piece of the puzzle during stim because, again, you're doing injections, you're going in for morning monitoring, you're already disrupting life, and now you have to pay attention to how much dosing you have left on your medications. It's like
it's a lot to keep track of.
It's a lot to keep track of, especially, if medicine is not like necessarily your forte and, chemistry and mixing all these things and doing these injections is just not just doesn't come second nature to you. You weren't, as it wouldn't to a lot of people, you weren't trained like a nurse or somebody that's, is used to this. That can feel very foreign. So I think that's a huge point that I bring up with a lot of clients too, is keeping track of your medications is super important. And it's going to help decrease your stress because you don't want to run out of something. The last thing you want to have happen is run out of something. And then that's a whole nother conversation and super annoying.
Never fun. Fun.
No, I think let's hit on symptoms. I think during stim,
okay, yeah,
that most people should expect. Just so people know high level what's normal and when to potentially call your provider.
Yeah, I think that's a great one. I mean, I always like to emphasize because I think people get hung up in the emotional side effects. What I really want to emphasize is that I think what most people, and again, everybody is different. We all have different body chemistries. But I think the majority of side effects of IVF are more physical, right? Soreness at the injection site, bruising, this feeling of fullness and being bloated and constipation, right? These are the things that I see most commonly. And yes, there can be this emotional component. And part of me always is like, how much of this is the process itself and how much of it is a side effect from the actual medication? And I think there can be a little bit of both, and then they bounce, they kind of intertwine and it creates this experience. But I get a lot of concerns from partners that are like, oh my gosh, is my significant other going to turn into like a raging monster?
Yeah.
And to reassure, like, again, I've seen a lot of things. I've seen a lot of people go through cycles. I would say in the majority of cases, that's not what happens, right? No. I think, again, it's a highly emotional time. I think what I tell people is you might be a little bit more sensitive to things, right? You might cry at a TV show that you normally would never cry at, right? You just become a little bit more sensitive, but you are not going to turn into a different person in the vast majority of cases.
Yeah. I usually tell people increase PMS symptoms.
Yeah.
Anything you tend to experience during that time of the month is potentially going to be heightened on these medications. So just like you said, fatigue, irritability, bloating, breast tenderness, backache, cramping, nausea, constipation, insomnia, like a lot of these things are very normal to potentially experience.
Yeah.
What I also tell people though is the absence or presence of the symptoms doesn't mean anything's wrong, good or bad. Right?
Yes.
Because I think
yes.
a lot of people, like, again, going back to social media, or their friend went through a cycle like, oh, they felt this and I'm not feeling any of this. Is something wrong?
Yeah. Well,
Or
I
you
think
are feeling something and you're thinking something's wrong.
and I think that's something we can get really deep into as well, like around whenever we get to a point of talking about like pregnancy test and
Yeah.
like post embryo transfer, that's like a huge
Yes.
component to it. And I think I want to be careful. I don't want our listeners to think, oh my gosh, I'm going to do IVF and I'm going to just feel horrendous, right? It's kind of like the side effect commercials you see on like on the TV for a new med. It's like, here's the things that you could experience, and it's like death, right? Or dizziness, heart attack. And it's like, okay, these are things that can happen. It doesn't mean that's the way it is for everybody.
Yes.
And again, I think that speaks to our individual chemistries. One bit of encouragement that I always like to give is estrogen rises really significantly during IVF. And estrogen is actually a happy hormone, right?
Yeah.
Like when we have estrogen in our system, it actually is like a euphoric hormone. That's why you hear a lot of horror stories of going through perimenopause and menopause and that depletion of estrogen, right? You start to have these different mood disorders that maybe weren't present when you weren't in perimenopause. So I just to give a little bit of encouragement there. I, for one, I actually felt fine during I was like, I'm happier than I've ever been. Physically I felt like garbage, but emotionally I felt okay. Again, my experience does not mean that's your experience, but I also want to like demystify a little bit this, because I think everybody assumes I'm injecting myself with hormones, and it absolutely means that I'm going to be a hormonal mess. These hormones that you're injecting are just higher doses of what your body makes naturally every month. We are not like giving you some crazy concoction that like
something
Pfizer
your body's
came up
never
with.
seen.
Right. These are legitimately hormones that you make every month anyway. So it's not like some crazy concoction.
Yeah, absolutely. Just higher doses. Yeah, 100%. I think that's a huge point. I think another thing too, oh my gosh, I'm losing my train of thought. I'll go back to something else. One thing I want to call out though is the bloating. I think this needs to be talked about more. I think it's the number one side effect for the majority of our patients that are experiencing or going through an IVF cycle. So I think if you take nothing else from this podcast today as a pro tip for going through an IVF cycle is hydrate like it's your job. Yeah. I tell that to everybody. Hydrate like it's your job. Something with electrolytes once a day.
I was going to say electrolyte fluids are a big one, right? Not always just straight water, but getting, and I think those low sugar versions too, right? Because we could go tell you to drink Gatorade, but if you're drinking the Gatorade, it has like 40 grams of sugar per bottle. Like that's also not going to be beneficial.
I really wish I liked coconut water.
Oh, that was a big one.
It's so good for you. And I hate it.
Even like there's like different flavors. I've
tried it. I have given the coconut water a try. Everything, every brand, different people have told me different brands, different flavors. I just cannot do it. But for those who really like coconut water or want to try it, that's a good one. Electrolyte, like natural electrolyte. But hydrate, lots of fluids, throw those electrolytes in. It's going to help pull that fluid off the tissues, help with the bloating. Huge pro tip from nurses in general as you're experiencing an
and yoga pants or pants with a stretchy waistband, I think too, because you can. I've definitely again, the goal of this is not to freak anyone out, but those ovaries get really big. I mean, I've seen ovaries the size of cantaloupes. Again, not going to happen for everyone, but it is a possibility. And so I tell people one of the feelings is you kind of feel like you're carrying a bowling ball around in your pelvis, and you will see that stomach expand. And this kind of goes to this concern I think a lot of patients have of weight gain. Mm-hmm. Most of that is temporary, right? We're telling you to fluid. Of course, we're going to see an increase in your weight. We're telling you that your ovaries get bigger. Of course, you're going to see that increase in weight. Majority of that is temporary and comes off in the 2 weeks following the egg retrieval.
Yeah, no, that's a really good call out. I remembered what I was going to say, that I think a lot of people assume, or it's something out there, that the more follicles or eggs that you have, the worse you're going to feel.
Mm,
In general, the more follicles or eggs you have, the bigger those ovaries are going to get, the more estrogen you potentially produce in your body. So yeah, in general, that's the theory. But I don't know about you, Laura, but I've seen that where it's not necessarily been the case. So
absolutely.
I want to debunk that too, since we're talking about this and throwing it out there, that just because, you have a certain number or higher or lower or whatever, that does not indicate you're going to feel a certain way or feel worse or feel better. It's just how your body's responding to everything.
And what your
So
tolerance level is too, right? Because
yes,
I've
no,
seen
that's a great call
patients with
out.
like huge ovaries and they're like, yeah, I feel
Yeah, I'm
fine.
good.
And I'm like, oh, okay, great. I'm glad you feel good. But right, that may be different
Yeah.
from Jane Smith,
Yes.
whose ovaries are the same size and she's like, feels like she can't handle it anymore. How much longer until this goes
Yeah.
away?
Yeah.
So let's kind of shift then to post egg retrieval. Kind of
Yeah.
on this note, I think a lot of patients assume, okay, we're going to go and we're going to have the egg retrieval and, oh, okay, I'm going to feel so much better, right?
Yeah.
So we're talking about this feeling of bloatedness and abdominal distension being a really common symptom of InStim. And I'm sorry to say that a lot of times it just doesn't go away right after the egg
Yeah.
retrieval. It tends to stick around for a little bit. We talk about, and you'll hear about, we don't have to go deep into this, but you'll hear
Yeah.
about things like ovarian hyperstimulation syndrome as being a adverse event that occurs with IVF. But the goal of IVF is to hyperstimulate the
Yeah.
ovaries.
Yeah.
And they do take time because those hormone levels are high to go back to a normal size. Most, I would say, a good amount of people doing IVF these days are not doing a fresh embryo transfer, meaning that you're not putting an embryo back in, within a couple of days after the egg retrieval. Rather, you're waiting for your body to get a period. And it's with that period, right, that those ovaries usually tend to start going back down to their normal size. And we say it's okay to resume activities. So always just stress, right? Like, don't expect you're going to go in for your egg retrieval and it's all going to be back to normal. It will take some time.
Yeah. No, I think that's a really good call out, because I agree with you. I think a lot of people think, okay, we've taken those eggs out. Hormones are done. I'm not injecting myself anymore. I'm going to start feeling good. And you will. I usually say 2 to 3 days
2 to 3
after that.
days. Yeah.
2 to 3 days after the egg retrieval, things might get a little worse before they get better.
Yeah.
Bloating
Yep.
might become a little bit more. And when you think about it, you've taken those eggs out. You still have all those hormones kind of floating around in your body, kind of doing its thing. We've just triggered, quote unquote, ovulation. We go get those eggs right before ovulation occurs at peak maturity. There's still a lot of hormones happening. And now we've taken what it was attacking or grabbing onto, or those receptors, we've taken them away. And now the body's like, okay. So I like to think of it as like a little bit of a hormone storm that's happening. Not in a bad way. It's just, hey, body's like freaking out a little bit for a second. So symptoms tend to get a little bit worse, 2 to 3 days. And then after 2 to 3 days, you're like, oh, whew, all right. Body's kind of figuring it out.
A little bit
Those
better.
eggs are gone.
Yeah.
I need to calm down a little bit. And you slowly kind of start to feel back to normal. I think having an episode on like more in-depth symptoms, kind of do's and don'ts during cycle and stuff like that could be really beneficial too, because I think we skimmed over a lot of stuff that could be really helpful, but we could again have an entire episode going over that. So hopefully at least the bloating piece was helpful to know what to expect. But I guess keeping along our timeline, we've had our egg retrieval. We've talked about a little bit about symptoms and stuff that happen afterwards, but what is happening with the eggs, the sperm? We're talking about IVF, right? Eggs and sperm. What's happening after we've taken those out? Let's go over kind of like the timeline and sort of, I think, what to expect so people have a realistic understanding. I think the reason I say this is I think a lot of people think, okay, especially if you're not doing a fresh transfer, again, everyone's going to be a little different. If you're doing PGT or genetic testing on the embryos, it's going to be a little bit before we can put those embryos back in. Yeah. I don't think people understand the length of time that really is. And I think that's a misconception. They're like, oh, next cycle or next period, I can go into an embryo transfer. And that's not the case if you've done genetic testing on the embryos.
Right. Well, and then again, we can just kind of high level say there's there's again nuances between protocols. There's natural cycle frozen embryo transfers. There's hormone replacement frozen embryo transfers. There's different types of hormone replacement embryo transfers. Some that use a month of birth control and Lupron, and others that just go straight into doing it right away. And there's no one right way or the other. It's just, I think a lot of it is physician preference and what they have seen success with or what they prefer to do for their patients, and just kind of how they've maybe always done things, right?
Yeah.
But I think, because I think this is where a lot of the emotional piece really comes into, right? It's like, okay, there's definitely emotions on, okay, how many eggs am I going to get retrieved? There's a lot of like anticipation. Okay, great. You get your eggs retrieved. I think this is where a lot of patients get thrown for a loop because they don't understand what happens with those eggs and what's normal.
Yes.
We talk about you'll hear the word, attrition.
Yeah.
And it can be really, what is the word that I'm looking for? Jarring, I think, when you see how much attrition can actually occur.
Yeah.
So like, just to take it, like, we'll play out a scenario of a patient who gets 20 eggs retrieved, right? And that could be, maybe you'll get that many retrieved, maybe you won't. Okay, so we get 20 eggs retrieved. We call egg retrieval day 0.
Yep.
We get an update typically from the laboratory. That may be by email. Somebody from the lab may call you. I would say a lot of clinics nowadays are emailing patients the day after portal. And saying, or a portal message and saying, okay, of the 20 eggs that we got retrieved, this is how many of those eggs were mature. An egg must be mature in order to fertilize. I don't think that again, is something that's talked about a lot. And then not every egg that we attempt to fertilize will fertilize. And I think that's normal. So maybe we had 20 eggs retrieved, maybe 18 of them were mature. And of those 18, maybe let's say 15, just because for number's sake, let's say 15 were fertilized. I would say that would be a pretty normal.
I would be very happy with that attrition. Yeah.
Yeah. And certainly we could see it more than that, or we might see, I've definitely seen people have all their eggs be mature and all their eggs fertilized. I would say that's more the outlier.
Yeah.
But that would be kind of a typical attrition. But to the average patient, you may think, oh my gosh, I had 20 eggs retrieved and now one day in, I'm down to 15.
Yeah.
And then this is where the big jump happens, is from that fertilization rate to the number of embryos that actually make it to the point where we can transfer them or perform a biopsy on them for PGT. Typically tends to be like around 1/3. Is usually, I don't know that's usually the statistic that I kind of use. So like, in that sense, right, if you had 15 that were fertilized, that you may only end up with 5 embryos.
Yeah.
And actually, that's a really fantastic outcome.
Yeah.
And again, you might have more, you might have less, but that seems like a really scary drop.
Yeah, it does. Yeah, you've just, lost 15 eggs that you retrieved, right? In your head, like that's gone down that much. And I'm seeing more and more of like on social media, there's trends, and maybe I shouldn't go into this because maybe we'll talk about this in part 2, but like, the flower trend. Have you seen this? Like everybody has like flowers in a vase and they start out with the number of eggs retrieved and they pull out the flowers that like they lose to attrition. We can talk more about this.
But I think it puts a visual to it.
It puts a really good visual, but then when you get to it thins it out, and that can be a really scary thing to, if you don't have that understanding of what is quote unquote normal. But again, everybody's going to be different. You may have more, you may have less. You could come out of the 20, you could have 0.
Yeah.
And again, that's not to scare anybody. This is also like, at some point it becomes less of like what's happening in the lab. It just becomes about genetics. It just becomes about egg meeting sperm, and they've got to do their thing. Once egg meets sperm, we watch it.
Yeah.
We are just looking at it. We're giving it a nice warm home to do what it needs to do, and we're watching it grow.
Yeah.
And there's nothing we can do to manipulate that or help it grow or make it become a blastocyst embryo. So I think having that understanding is really important. So just to give a timeline to this really quickly. So like Laura mentioned, day 0 is the egg retrieval. Day 1 is usually you find out how many eggs were mature and how many successfully fertilized. And then an embryo can reach blastocyst around day 5 to day 7 of an embryo's life. So that's 5 to 7 days after your egg retrieval. You should find out how many of your fertilized eggs reached a blast or blastocyst. If you're doing PGT testing or genetic testing on the embryo, that's when the biopsy will happen. They'll take a couple cells from that embryo, and then they will freeze that embryo. Mm-hmm. Embryo usually stays on site at your clinic, or at least goes to the storage facility where it's going to live. Every clinic is going to be a little different.
Yeah, I think it's important to point out we don't actually send an embryo out.
A lot of people think we send your whole embryo out, and that's not the case. Your embryo is going to be frozen and stored at the lab that you were told is going to be stored at. Yeah. And then the couple tiny cells, those go to the genetic testing lab, or again, that could be internal with your clinic. That could be an external testing lab. So we're a week out from your egg retrieval when this is happening. And then usually genetic testing takes around 2 to 3 weeks. And again, every clinic is going to be a little different. Every testing lab is going to be a little bit different. But so we sent out the samples 1 week after egg retrieval. And now let's say it's 3 weeks and you get your results. You are now a month after your egg retrieval.
Mm-hmm. Yeah.
So you've already had a period, most likely. Most people, depending on your trigger, everyone's going to be a little different on when you get your period.
Like 10 to 14 days post-retrieval. And side note on that, I think people forget that your natural cycle, if you had 28-day cycles, your cycle's been manipulated. When you're doing IVF, you no longer just pretend your cycle doesn't exist anymore, because we are completely manipulating it now. So you can't, I get a lot of people that are like, well, I should have got my period because it's day 28. My calendar says I should have got my period. Yeah. That's not the case. We have manipulated things. I think a good rule of thumb is 1.5 to 2-ish weeks post-retrieval is when you would get your period.
Yeah. And again, it depends on trigger. So if you do like a loop run only trigger for some people, that it may be a little shorter, but your clinic should give you. But anyways, you've already had your next cycle, your next period, your next cycle has already started, and you might be midway through that next cycle before you get those embryo results back. And then it's conversation of how many were genetically normal, which is called euploid. Genetically abnormal is aneuploid.
Yep.
I think we could have an entire conversation, maybe even bring on an embryologist at some point talking about PGT, talking about mosaics. I think that's a big question that a lot of people have a lot of questions about. We could get way, way more in depth on that. But again, you're now a month out from that egg retrieval just to get your initial results if you do PGT testing. And then fingers and toes crossed, of the 5, let's say in Laura's scenario where we were talking about, of the 5, there's an attrition rate there too. Not all embryos, you could have 0. You could have all 5 that are normal. At that point, again, it's really genetics. It's egg quality, it's sperm quality, it's DNA, it's everything that's sort of out of our control, to give us, hey, is that embryo normal or abnormal?
Yeah.
And then it's conversation with your doctor about do you do another cycle? Do you do an embryo transfer? If you have something to transfer, everybody again is going to be different in what they decide. I think I'll throw this out there really quickly. I think I get this question a lot, right? Like, what's a good number? Yeah, what number should I be hitting to know when to not do another egg retrieval or to do a transfer, or like that question comes up, I'm sure, a lot for you and I as coaches and coaching, helping people through the process. And that's a hard question to answer. I think that's where you kind of educate yourself on age. I think,
how many children
do you want? Yep. Family planning. It goes, it's way bigger than what's a good number. If my AMH or AFC, I'm talking about fertility tests. If my fertility testing numbers show this, what should I be hoping for if I want this many kids?
I think it's a nuance, right? It's very nuanced again, and I think we'll keep drawing back to this throughout the podcast as we continue to have episodes. But I think the big takeaway is it's not linear. And so these are really individualized, and what is a good number for one person may not be a good number for another person. And again, that plays in factors such as your age, timing to family completion, how many children you want to have. There can be a gender specific, component to that. If you have, PGT does tell us about embryo gender. And so maybe you want a boy first or you want a girl first, but you only have one boy embryo, right?
Yep.
And there's a whole ethical component to that. I mean, there's just so many things. A lot of what we've talked about in this episode, and just, I think the theme of this has really been IVF and the factors that are out of your control, right? A lot of what we've talked about are factors that are out of your control. We can't necessarily control when insurance approves, a cycle. We can't necessarily choose if you have a cyst at the beginning of your cycle. We can't control that. There's nothing that I could say, okay, cysts happen for some people before they start IVF, but if you do this, right, then you won't have a cyst, right?
Yeah.
It's out of our control. It's out of our control what that attrition rate is. There are things, that are within our control that can somewhat influence these factors, but I would say the majority of everything we've talked about is things that we can't control. And I think where we're shifting next week is to things that maybe we can control, and maybe how social media has influenced some of that. And some of it is for good, but some of it is not. But I think in fertility, what's so hard and why it's so emotionally charged is because there's this lack of control.
Yeah.
And that's very difficult because this is a very, you want a baby, right? That's like why you're going through this. And to not be able to control that outcome and feel that sense of loss of control can be anxiety and stress inducing and difficult.
Yeah, no, absolutely. And I think that's a great segue for our next week's podcast, or part 2, is I think we want to dive into some of the things that we're seeing on social media and kind of say, yeah, that has some legitimacy, and no, that will absolutely do nothing.
Yeah.
and I think we want to, I think we want to talk about this more, because I think a lot of us are on social media, personally, professionally. We scroll a lot, and you get sold things all the time. You see things all the time. Maybe, part of your fertility community is through social media, and it's so hard to kind of disengage and you listen to yourself that, yeah, I know that I shouldn't be comparing to so-and-so, or, oh, I know that they might, this vitamin may not fix everything, but what if it does?
Yeah.
So I think we want to go into that. We want to talk about kind of what's out there. We've sort of told you what we see all the time, questions that we get a lot, really dive into, IVF, what people probably haven't told you about the process.
Mm-hmm.
And again, it's not to be negative. It's just meant to set your expectations and tell you about what could happen. And I think the more information, the more clarity, the more you understand, the more prepared you're going to be for the process. And that's the goal of this, is just to set your expectations clinically, financially, emotionally, physically, all these things. We wanted to set that up for you, right?
Yeah.
And that was the goal of this. And now I think we want to take a step back and say, okay, what's happening out there in the world that they're telling you, oh, this will prepare you for IVF, or, oh, this will prepare you for pregnancy.
Or, oh, this is the way it should go. And if you don't follow this exact timeline that I'm telling you this should happen in, right, somehow you failed.
Yeah. Yeah, we wanted to be very real in this first part. And then in the second part, I'm really excited about that conversation, because Laura and I love calling out things that are not real. But I think what you'll, in part 2, I think we're going to squash. I think what happens in hearing and seeing all these things is it unintentionally creates blame. Of you did or didn't do something, and that caused the IVF cycle to fail, or that caused the pregnancy to not happen. And we want to remove that, right? We want to tell you what's real, unfiltered, going through everything, and decrease the pressure on you, but also give you some tips and tools and tricks that are evidence-based or clinically proven, that, yeah, if you did some of these things, it could potentially help you, but also not create this image like social media does of perfection.
Yeah. Yep.
So stay tuned for part 2, where we dive into all of that. I'm excited for that conversation.
I am too.
But I do hope that today's conversation resonated with you, have a better understanding of kind of IVF, what people don't tell you potentially about the process, maybe what people are not talking about, to set your expectations and give you just the best possible chance of success possible. So if this did resonate with you, please comment, like, share, let us know what you thought. If you have comments, if you agree with us, if you disagree with us, again, we want to hear from you. We're going to say that in every single episode because we 1,000% want that. We want this to be a conversation. And so comment, like, share, subscribe, let us know what you think. And we are excited for next week's episode where we dive into part 2.
Yeah. Awesome. Well, we'll leave it at that. And we will see you next week. Have a good one, everybody. Bye.
If this conversation resonated, like, comment, or subscribe, share, send us your questions. Nothing is off limits.
And wherever you are in your journey, know this: you deserve support that's real and human. Never forget to ask your questions, advocate louder, and remember, you're not crazy. Fertility is hard.
That's it for today's episode of Fertility Nurses Unfiltered. Thanks for spending your time with us today.
We'll see you next time.